In this orthokeratology case, we have a patient who is a little bit undercorrected and has some residual astigmatism after lens wear. We look at the post-wear and pre and baseline topographies. I'm going to pull up a difference map. We can see we're just not getting very even central flattening, and there's an area around the apex where it's almost no treatment at all. So not really a central island, but an island where we're getting significantly less treatment than surrounding areas. So I would try to reduce the sagittal depth of this lens overall so we get some more bearing at the apex. And here's the lens that the patient is wearing for the left eye right now. Um, this one's in freeform. It looks like you were doing a little GSIM versus freeform experiment, which I love to do with my patients. And I think it's possible that this steep area here that we see on the topography is causing wave to create a lens that is a little bit too tight or has a little bit too much sag superiorly, and that could be causing some of our problem. If we go to a GSIM lens, we'll see that it's not a whole lot. It flattens out a little bit, but that's probably what I would recommend doing. Usually what I'll do is erase these Myers for these irregular areas of the topography so that it doesn't add any confusion to the lens design. And then GSIM and maybe even lift the periphery a little bit, maybe 10 microns or so. So 960. To 950. So this will give us an overall more shallow lens and should give us a little bit better central compression. So the only caveat is this lens does look like it rides a little bit high, and usually when we flatten the lens, that will cause it to ride even higher. So we'll have to keep an eye on the centration. Another thing is I think we can go maybe a little bit larger on the overall diameter. I measure very generously for OAD and 11.5-ish, so we can probably go to like an 11.3 on this lens, and that may help a little bit with our centration. And then the last thing I would do is 122 is probably okay for most -4 corneas, but it's kind of a flatter cornea to begin with, and we're undercorrected, so I would probably increase the power here to 150. I think if we get better, even though this cylinder, corneal cylinder, does extend past the center of the cornea, if we can correct half of it and get us around a half or so of residual cylinder, the patient should be okay without going to an oval treatment zone or toric treatment powers. So hopefully that's helpful. Those are my thoughts. Best of luck on your patient.